Hello guys, welcome back to MEDICO DIY, and today in this video we'll be talking about Hyperemesis Gravidarum. Before talking about Hyperemesis Gravidarum, let's talk about vomiting in pregnancy. Vomiting in pregnancy can either be present as an association with pregnancy, or it can be related to pregnancy. All the gynecological, medical, and surgical causes are associated with pregnancy. And if the vomiting is itself due to pregnancy, then depending upon the severity, it can be of milder type or severe type. The milder type, it is known as simple vomiting or emesis gravidarum, or it can be also called as morning sickness. While the severe type is known as hyperemesis gravidarum, which we'll be dealing in the later part of the video. Talking about the causes of vomiting in pregnancy, the vomiting can either occur in the early pregnancy or in the late stage, and in both the stage, as I have said earlier, it can either be due to related to pregnancy or associated with pregnancy. In the early pregnancy, the vomiting can be due to related to pregnancy, as in morning sickness or hyperemesis gravidarum, or it can be associated with pregnancy. There may be various causes, like the medical causes includes intestinal infections, UTI, pyelonephritis, hepatitis, DKA, uremia. The surgical causes can be peptic ulcer, appendicitis, cholecystitis, pancreatitis, intestinal obstruction. And the gynecological causes can be torsion of the ovarian tumor or the red degeneration of the fibroid. Similarly, in late pregnancy also, it can be either related to pregnancy, that is the continuation or reappearance of morning sickness or acute fulminating preeclampsia, or it can be associated with pregnancy, as the causes which I've mentioned before, like the medical, surgical, and gynecological causes, or the hiatus hernia. This is about the simple vomiting in pregnancy. Now let's talk about the milder form of vomiting in pregnancy, that is emesis gravidarum or morning sickness or simple vomiting. The morning sickness or the simple vomiting, it is one of the common complaints of the pregnant ladies in the first trimester. Here, the patient, it complains about nausea and occasional sickness on rising in the morning, but the vomiting can occur at any part of the day, and the vomitus is usually small in amount, and it is either clear or bile stained, and the vomiting is not so severe such that it does not produce any impairment of the health or restrict the normal activities of the woman. The cause of the milder type of vomiting in pregnancy, that is the morning sickness, is due to increased level of beta-HCG, estrogen level, and altered immunological states. The management of the emesis gravidarum or morning sickness is that it usually does not require any treatment, and the symptoms usually disappear with or without treatment by 12 to 14 week of gestation. So hence assurance plays an important role in the management of such patients, and in the diet, small feeds should be given and frequent feeds should be advised. Dry toast or biscuit can be taken by the patient, and the patient should avoid the fatty meals and spicy foods. And since the vomiting also causes deficiency of vitamin B1, so supplementation of vitamin B1 may also be given. And if the patient does not get cured with these normal treatment, then antiemetic can be given, and trifluperazine 1 milligram twice a day can be given. And since the patient is repeatedly vomiting, so there will be fluid loss, and to replace the fluid, the patient is advised to take plenty of fluids, at least 2.5 liters in 24 hours, and fruit juice can also be taken. This was about simple vomiting or morning sickness or emesis gravidarum. Now let's talk about our main topic of today's video, that is hyperemesis gravidarum. Hyperemesis gravidarum, as I've mentioned earlier, it is a severe type of vomiting occurring in pregnancy and has got deleterious effect on the health of the mother and or incapacitates her day-to-day activities. This severe vomiting, it results in dehydration, alkalosis, metabolic acidosis, electrolyte imbalance, and weight loss in more than 5% of the cases. The dehydration occurs as the fluid is lost in vomiting, and alkalosis occurs because there is loss of H plus ions in the vomiting due to loss of HCl. that is gastric acids. And metabolic acidosis occurs due to starvation. The patient does not eat as there is continue vomiting, so this results in acidosis. And in the vomitus there is loss of sodium, potassium and chloride ions, resulting in electrolyte imbalance. And since the patient also refuses to eat, this results in weight loss in long term. Hyperemesis gravidarum, the incidence has decreased in the recent days because there is less cases of unplanned pregnancy, because unplanned pregnancy, it is one of the risk factors for hyperemesis gravidarum. And nowadays there is early antenatal clinic visits, and even if the patient has vomiting, there are potent drugs, that is antihistaminics and antiemetic drugs, which helps to manage the patient in the early stages. Talking about the etiology, the exact cause of hyperemesis gravidarum is not known, but usually it is seen that the hyperemesis gravidarum cases occurs in the first trimester of pregnancy, and it usually occurs in patients of younger age, that is less than 30 years. And if the patient has first pregnancy, then they have high chance of having hyperemesis gravidarum. And as I have said earlier, it is also common in unplanned pregnancy, multiple pregnancy, molar pregnancy and family history. Family history is very important. If the mothers and the sisters have had the history of hyperemesis gravidarum, then there is high chances that the patient will also have hyperemesis gravidarum. And if there is also high chances of having hyperemesis gravidarum in patients with history of migraine or motion sickness, and in those who have has nausea and vomiting when using the combined oral contraceptives. The theories regarding the hyperemesis gravidarum can be divided into 5 topics. That is, it can be either due to hormonal cause, psychogenic, diet, altered immunological basis, and decreased gastric motility. In the hormonal causes, it can be due to increased beta-HCG, as the studies have shown that beta-HCG is increased in molar pregnancy and multiple pregnancies, and this multiple pregnancy and molar pregnancy have increased chances of having hyperemesis gravidarum. And vomiting also occurs at the peak of the level of the HCG in the body. Increased estrogen level is also one of the causes of developing hyperemesis gravidarum. And during pregnancy there is also increased progesterone level, and this increased progesterone level, it relaxes the cardiac sphincter, and it also causes retention of the gastric fluids due to impaired gastric motility. The cause can either be psychogenic or diet, as since the vomiting occurs mainly in the morning, it can be due to lack of carbohydrate reserve due to overnight fasting without food. And the vitamin B1, vitamin B6 and protein deficiency, it may be the effects of vomiting. And decreased gastric motility, it causes nausea. In the patients of hyperemesis gravidarum, a vicious cycle occurs. That is, when the patient has severe excessive vomiting, the patient will have decreased food intake, and severe vomiting results in dehydration, and the patient will have carbohydrate starvation, and this results in ketoacidosis, and the ketoacidosis itself results in excessive vomiting. So in such patients, the vicious cycle occurs. Talking about pathology, the pathology is due to the generalized manifestations of the starvation and severe malnutrition. In the liver enzymes may be elevated. The kidney may be normal, but in some cases fatty changes is seen in the cell of the convoluted tubule. The heart in such patients is usually small, and they also have subendocardial hemorrhages. In the brain there can be vernix encephalopathy, and metabolic changes are also seen. The patient will have acetone in the urine and breath, and will be increased level of the urea and uric acid. And the presence of acetone in the urine and breath is due to the fact that during hyperemesis gravidarum there is decreased intake of food. So this results in glycogen depletion. This causes breakdown of the fat to produce energy, and since there is low carbohydrate, there will be incomplete oxidation of the fat, incomplete breakdown of the fat, producing acetone, and this acetone, it accumulates in the blood and is excreted in the urine and in the breath. In the biochemical changes, we can see that there is presence of acidosis due to starvation, metabolic alkalosis due to loss of H plus ions, and there will be hypokalemia, hyponatremia, and hyperchloremia, ketosis, blood urea, uric acid will be increased, hypoglycemia, hyperproteinemia, and hypervitaminosis will be present. Those changes in the circulatory system will be that there will be hemoconcentration, so there will be increased level of the hemoglobin, RBC, and hematocrit value, and there will be slight increase in the WBC with eosinophilia. Talking about clinical course, the patient is usually of younger age, as stated before, usually in a first pregnancy and with insidious onset. According to the clinical course, the hyperemesis gravidarum can either be early or late, and early is said when there is features of dehydration and starvation is absent, and late when the features of dehydration and starvation is present. The symptoms usually includes vomiting, which occurs throughout the day, affects our daily activities, and there is increased frequency and retching with epigastric pain and constipation, and there will be decreased urine output, and the signs of complications may also be present. Talking about signs, there will be features of dehydration and starvation. The patient will have dry coated tongue, sunken eyes, acetone smell in breath, tachycardia, hypertension, rise of temperature, and jaundice in late feature. And we should know that if the patient can have oral feeds or not, depending upon which admission is done. The differential diagnosis of the hyperemesis gravidarum is that the GI causes should be ruled out, like peptic ulcer, which has relation to food, cholecystitis, pancreatitis, hepatitis, in which the liver function test will be deranged, and appendicitis. It should also be differentiated from food poisoning and gastroenteritis. In gastroenteritis, the patient will also complain of diarrhea, and it also should be differentiated from diabetic ketoacidosis, pyelonephritis, and gynecological cause like torsion of the ovarian tumor and the degeneration of the fibroid. In investigation, the first thing we need to do is to confirm pregnancy by urine pregnancy test if the pregnancy has not been confirmed yet, and urine examination needs to be done, where the urine volume should be noted, which is usually small and is dark colored. There may be presence of acetone, so acetone, albumin, sugar level should be checked, and chloride level should also be checked, which is usually low or absent. In the blood, random blood sugar should be done to rule out diabetes mellitus, and electrolyte level should be measured to note the improvement of the patient in the treatment phase. The liver function test and the thyroid function test should also be done, as the patient may have transient thyroid dysfunction, and USG is done to rule out multiple pregnancy, molar pregnancy, and other causes of the excessive vomiting. And since the patient has severe vomiting, so there can be retinal hemorrhage or retinal detachment, which should be ruled out by ophthalmoscopic examination. And if the patient has hypokalemia, then ECG should be done. The complications of hyperemesis gravidarum is that since there is severe vomiting and starvation and electrolyte imbalance, different complications can set in, and the complication can either be limited to the mother or it can also involve the fetus. Talking about the complications in the mother, it can be either neurological complications like wernicke encephalopathy due to vitamin B1 deficiency, Korsakoff psychosis, peripheral neuritis, beriberi. The patient may undergo go into coma or convulsions. There can be esophageal rupture, malaribiasteria due to severe vomiting. There can be stress ulcer in the stomach. Jaundice and hepatic failure may set in. Hyperprothrombinemia may occur due to vitamin K deficiency, and renal failure may also occur. In the fetus, the baby may have a preterm birth, and the baby may have low birth weight. Talking about management, there are certain common methods which have been used to treat hyperemesis gravidarum, like taking small feeds at the time, or and taking the feeds in frequent intervals, drinking fluids between the meals, and the patient should be advised not to lie down immediately after food intake, and to avoid the food that causes gastric irritation, and to avoid high fat content food. The principles in management of hyperemesis gravidarum is that the main aim is to control the vomiting and to hydrate the patient, since there is excessive fluid loss due to repeated vomiting, and due to vomiting there is fluid and electrolyte imbalance. So this fluid and electrolyte imbalance should be corrected, and since there is metabolic disturbances too, so this too needs to be corrected, and to prevent complications and the care of pregnancy is important. So um, as the patient is diagnosed with hyperemesis gravidarum, they should be admitted, especially those patients who is not able to take oral feeds or is severely dehydrated, not treated with medical management, and there is presence of complication. Those patients should be admitted in the hospital. And since the patient is having repeated vomiting, so the patient is kept in nil per oral for at least 24 hours after the cessation of vomiting. The fluid and electrolyte correction is done. IV fluids is given 3 liter approximately, which contains 50% of dextrose and 50% of regular lactate. And extra fluid needs to be added according to the fluid which is lost in vomitus and urine in 24 hours. The enteral feeding can also be done via NG tube. Since there is vomiting, antiemetics needs to be given like promethazine, chlorperazine, and doxylamine with or without vitamin B6. And doxylamine, it is also potent antihistamine. In severe cases of patient with intractable vomiting or with hypertension, hydrocortisone has been used. 100 milligram IV drip is given. Since there is loss of vitamin B1, vitamin B6, so vitamin B1, B6, and B12 and vitamin C can be given as a nutritional supplements. And talking about the nursing care, sympathetic but firm handling should be done. In the hospital, hyperemesis progression chart can be used, which is helpful to assess the progression while the patient is in hospital. Talking about the diet, before discontinuing the IV fluids, the oral feeds should be started by first giving the dry carbohydrate foods like biscuit, bread, and toast. And if the patient tolerates these foods, then small frequent feeds is given, and gradually the full diet is restored. And the clinical features of improvement are subsidence of vomiting, feeling of hunger, the patient has a better look, and there is normalization of the biochemistry, and pulse, BP, and urine output, and there will be disappearance of acetone from breath and urine. These are the signs of improvement in the patient. Thank you guys for watching the video till the end. I hope you all found this video useful, and if you like this video, then give this video a thumbs up, and do share this with your friends. And if you have any kind of suggestions, then you can comment in the comment box below, and stay tuned for more videos. Thank you.